Dear students, welcome to our cardiology department. My name is Dr. Eslam Bastawy, lecturer of cardiology at Shams University. Our talk today is about infective endocarditis. By the end of this lecture, you should be able to understand the pathophysiology of infective endocarditis, to identify patients at risk of developing infective endocarditis, to know how to diagnose infective endocarditis, and to know the treatment strategy, including when to refer patients to surgery. We will start by the definition. Infective endocarditis is defined as the infection of the endocardial surface of the heart. Endocardial surface of the heart includes cardiac chambers, heart valves, great vessels, or lining of congenital anomalies like septal defect, atrial septal defect, or ventricular septal defect. Infective endocarditis is commonly bacterial in origin, and the most common causes of infective endocarditis due to bacterial infection are staphylococci and streptococci. Other causes of infective endocarditis are fungi, fungal infection, or infection by intracellular organisms like rickettsia or chlamydia. The pathophysiology of infective endocarditis: it may be subacute or acute infective endocarditis, and there may be overlap in the presentation of infective endocarditis between the acute form and the subacute form. Acute infective endocarditis usually occurs due to highly virulent organisms like staphylococci that are able to affect normal heart, leading to severe illness and associated with worse prognosis. Subacute infective endocarditis occurs due to infection by less virulent organisms like streptococci, and it's typically occurring at sites of pre-existing endocardial damage, as with diseased cardiac valves and on top of septal defects. The whole pathological mark of infective endocarditis is the vegetation, which is formed of the infective organism, platelets, and fibrin. Infection tends to occur at site of endothelial damage because the site of endothelial damage attracts deposits of platelets and fibrin, forming a thrombus, which is vulnerable to colonization of infective organisms. We have to know that endocardial damage may occur due to high pressure jet of blood, such as ventricular septal defect, mitral regurgitation, aortic regurgitation, more than to occur with low pressure jet of blood, as with atrial septal defects. Vegetation may increase in size, leading to valve obstruction, and may destruct valvular tissue, leading to valvular regurgitation and heart failure. Extension of infection may lead to abscess formation or extension to AV node, leading to AV nodal conduction abnormality. Extracardiac manifestations of infective endocarditis include embolism and immune complex deposition. The most common causes of bacterial infective endocarditis are streptococci and staphylococci. Streptococci as Streptococcus viridans, Streptococcus pneumoniae, and Streptococcus pyogenes, and we have to know that Streptococcus viridans are a group of streptococci that are found as the normal commensal flora in the mouth, and it enter the bloodstream with teeth brushing, chewing, or with dental procedures. Staphylococci may be coagulase positive staphylococci like Staphylococcus aureus, or coagulase negative like Staphylococcus epidermidis. Staphylococcus aureus is a highly virulent invasive organism that originates from skin infection, abscess, or vascular access sites, and it's the most common cause of infective endocarditis that occurs in the IV drug abusers. Staphylococcus epidermidis are skin commensals that may cause early prosthetic valve endocarditis that occurs within first year after cardiac surgery. Other organisms responsible for infective endocarditis are enterococci, which are gram-negative bacilli that may enter the blood from the bowel or urinary tract. Hasek group, which are group of slowly growing gram-negative organisms like Haemophilus, Actinobacillus, Cardiobacterium, Echinella and Kingella. Procella, which is associated with a history of contact with animals like cattle and goats, or fungi like Candida or Aspergillus that affect immunocompromised patients. Clinical picture of infective endocarditis include a predisposing condition like history of previous cardiac disease, previous infective endocarditis, prosthetic valve, or IV drug abusers. Constitutional symptoms or manifestations due to toxemia like fever, malaise, night sweating, and weight loss. Heart failure with new cardiac murmurs. Embolic complications due to systemic embolization and immune complex deposition manifestations. Systemic embolization may occur with infective endocarditis due to embolization of a detached part of vegetation that may lead to cerebrovascular stroke, renal infarction, retinal infarction, splenic infarction, acute limb ischemia, mesenteric ischemia, or nail fold infarction, while immune complex deposition lead to vasculitic manifestations like Osler's nodes, Ross spots in fundus examination, and glomerulonephritis. There are two characteristic lesions with infective endocarditis like Osler's nodules and Janeway lesion. Osler's nodules are tender erythematous lesions or nodular lesions at tip of fingers, which is one of the manifestations of immune complex deposition, while Janeway lesion occur at the palm or sole, and it's one of the manifestations of systemic embolization. Now we reached the end of the first part of this lecture, and we will continue the other part later. Thank you.